Good morning and good afternoon and good evening to everyone who's joining us from around the world. On behalf of the International Atherosclerosis Society and the Inflammation Academy Fellows, it's really our pleasure to welcome you to today's webinar, What Imaging Tells Us About Inflammation. My name is Shadi Abu Hashim. I'm an IAS Inflammation Academy Fellow, and I will be moderating today's session. So we will focus on how modern imaging is helping us move beyond the stenosis, kind of toward visualizing inflammation, plaque biology, and the processes that precede cardiovascular events. Here's how we will structure our next hour. We will begin with a brief overview of the AIS and Inflammation Academy, followed by kind of two focused fellow presentations. After each talk, we will have a panel discussion with our expert guest, Dr. Marta Gulati and Dr. Dinesh, and we will incorporate your questions live. Next slide. So just a few words about the Inflammation Academy. From a competitive global application process, IS has selected 30 physicians and scientists from 25 countries to kind of form this inaugural cohort. The Academy was created to identify and develop the next generation of leaders in inflammation and cardiometabolic disease. Next slide. So this is our 2025-26 cohort representing kind of diverse disciplines and geographies and perspectives. But we are united by a common focus is understanding inflammation as a central driver of cardiovascular disease. Next. Over the course of the year, we kind of engage in in-person learning and thought leadership initiatives in a series of webinars that are led by the fellows with faculty mentorship. And next, and today's webinar is one of the 4 fellow-led sessions in this series, which is led by our faculty mentor, Dr. Jessica Penny. Next. So our focus today is imaging inflammation. And we know imaging has evolved from detecting luminal narrowing to characterizing plaque by morphology, and now to interrogating biological activity. And that's the key theme for our today's discussion. So it's my pleasure to introduce our first speaker, Dr. Tatiana Storzenko, who will discuss non-invasive imaging approaches and what we can assess today and what we may be coming next. Tatiana, the floor is yours.
Hello, everyone, and thank you, Shadi, for this kind introduction. It's really a great pleasure to be part of the Inflammation Academy and to speak about 2 topics I'm passionate about, imaging and inflammation. And to start our discussion, I think it's quite important to highlight why imaging inflammation matters today and why looking at the stenosis alone is no longer enough. Next slide, please. Over the past 5 decades, we have moved from coronary angiography to AI-powered plaque quantification. And in other words, we have shifted from simply measuring how narrow vessel is to understanding the biology that makes plaques dangerous. But despite this impressive progress and variety of imaging modalities available today, I think that tools are still significantly underutilized in clinical practice. Next slide, please. What do clinicians actually need from imagers? 2 things. First, risk stratification, and second, and this is the hardest one, I think, detecting which plaques are likely to cause acute coronary syndrome. Basically, we need imaging that can guide management decisions to identify patients who need lifestyle modification only and who needs aggressive risk factor treatment and who needs intensive global risk reduction. Next slide, please. And I really love this illustration because it captures the problem perfectly. For a long time, we have been focusing on the myocardial ischemia and managing angina. But angina and prognosis are not the same thing. And ischemia tells about flow limitation, but it doesn't tell which plaque is about to rupture. And the real threat to prognosis is a high-risk plaque. Next slide. So 3 main mechanisms cause acute coronary syndrome. Plaque rupture accounts for around 60% of cases, and this is a classic thin cap fibroateroma with a large necrotic core that ruptures. Superficial erosion is responsible for 30 to 35% of cases and more common in young patients and women. and calcified nodules cause about 5%. And importantly, the most of these events occur at site with less than 50% of stenosis. So it means the biology, inflammation, thin cup, large lipid core, this is what drives events, not only stenosis severity. Next slide, please. Let's look at our imaging toolkit. On the left, you see what's inside a vulnerable plaque, and different modalities can detect different components. On the right, the same lipid-rich plaque visualized by coronary CT angiography, virtual histology IVUS, NIVS, OCT, AI composition analysis, etc. And each modality gives us a different window into plaque biology. Next slide. And let me show you how this works in practice. Here's the same LAD lesion viewed with 4 different modalities. And this is where I think is everything comes together. So on coronary angiography, we see mild stenosis and nothing alarming. But if you look on the CCTA, it shows mixed plaque with adverse features. And IVUS reveals significant plaque burden and positive remodeling. You can see that vessel has expanded outward and accommodate disease. And OCT shows us the microstructure. So the same stenosis and very different risk. And each modality adds a layer of understanding. Next slide, please. What specific features should we look for on coronary CT angiography? First, low attenuation plaque. That's less than 30 Hounsfield units, indicating lipid-rich necrotic core. Positive remodeling, the vessel expand outward. Napkin ring sign, a low attenuation core with high attenuation ring, and spotty calcification. Multiple studies and trials, including CONFIRM-2, and Scott-Hart, showed that plaque burden and adverse plaque features carry prognostic information beyond stenosis alone. And as you can see in a Scott-Hart, patient with non-obstructive disease, but with adverse plaque features had a higher 5-year risk of myocardial infarction compared to those with obstructive disease, but no adverse features. Next slide, please. But intravascular studies demonstrated that lesion level prediction was modest, and many plaques with high-risk features do not trigger events during follow-up. And even more, some events arise from lesion not classified as a high risk. So the gap between patient level and lesion level prediction is precisely why we need inflammation imaging. It tells us about which plaques are biologically active and brings us to perivascular fat attenuation index. Next slide, please. So the idea of this method is following. When the coronary artery is inflamed, it releases cytokine into the surrounding perivascular fat, and these cytokines inhibit adipocyte differentiation, increase water content in the fat, and this changes the CT attenuation. So as you can see, inflamed vasculature shows red-orange fat with higher Hounsfield units, and we can measure these shifts and use it as a biomarker of coronary inflammation, derived just from the standard coronary CT angiography. Next slide, please. The CRISP-CT study over 3,900 patients showed that the high fat attenuation index significantly predicted all-cause and cardiac mortality. And even more, a look at the right panel. When you combine high fat attenuation index with high-risk plaque features, the hazard ratio for cardiac risk increases. Next slide, please. So where may fat attenuation index fit in a clinical practice? First, for patients with no atheroma on coronary CT angiography for primary prevention. And second, for those with non-obstructive or obstructive disease for secondary prevention. It helps identify vulnerable plaques, guide treatment escalation, and even response to therapy. Next slide, please. In conclusion, I would like to say that non-invasive assessment of coronary anatomy, plaque morphology, and inflammation is not a replacement for invasive assessment, but rather a means to identify patients who can be managed medically and those who most likely to benefit from invasive evaluation. Thank you for your attention, and I look forward to the panel discussion.
Thank you, Tatiana. That was a clear and forward-looking overview of how non-invasive imaging is actually reshaping our understanding of plaque vulnerability. So now it's my pleasure to bring in our expert panelist for discussion. So joining us today, Dr. Dinesh Kalra is a division chief of cardiology at University of Louisville. Dr. Kalra's work spans multimodality cardiac imaging, lipidology, and preventive cardiology. He has led numerous clinical trials focusing on atherosclerosis and heart disease prevention, contributing significantly to innovative research and patient care. And he was recently named the incoming editor-in-chief of JACC Advances. And we're also honored to have Dr. Marta Gulati with us, an internationally recognized leader in preventive cardiology and women's cardiovascular health. She serves as the inaugural director of the Backy Heart and Vascular Center Women's Heart Program at Houston Methodist, and she is the immediate past president of American Society for Preventive Cardiology. Her leadership has shaped our major guidelines, including the 2021 HHA chest pain guideline. Thank you both for joining us today. We are really grateful for your time and insights. So I will start with a broad framing question first for both of you, and this is a reminder for our audience. Feel free to shoot in your questions in the live chat. We will take some of those questions. I'll start with a broad framing question for both of you. As imaging evolves from stenosis assessment toward plaque biology, what do you think is the biggest conceptual shift that clinicians need to make?
Well, I can start, if that's okay with you, Shadi. Thank you first for the invitation and for this fantastic academy and the work you're doing. So I think the evolution of imaging for coronary disease has undergone a massive shift, as you mentioned, from focusing only on patients who initially we were identifying tight stenosis and ischemia as a cause of their symptoms, to now being more comprehensive and shifting into the preventive space. Because as you know, the vast majority of patients we image do not actually have obstructive disease. But we do find a lot of individuals who have non-obstructive plaque. And what the past 15 years of coronary CT imaging has taught us, that non-obstructive plaque, what we used to call normal on invasive angiographies, actually portends a worse prognosis. So the presence of 3-vessel non-obstructive plaque carries a MACE risk similar or approaching that of 1-vessel obstructive plaque. So our paradigm shift has been towards earlier preventive therapy and trying to identify which patient is going to be the vulnerable patient who in the presence of non-obstructive plaque is going to have an event. I think that's been the biggest shift over the past 20 years.
Yeah, I'd agree with Dr. Kalra that, many years ago, I feel like that's all we focused on was obstructive coronary disease. And I remember very distinctly this figure that guided us during our training, or at least my training, saying that you could only have symptoms and signs of ischemia when you had an obstructive lesion. So they'd show plaque, and by the time you had narrowed plaque, above 70%, that was the only time a stress test could be abnormal. And that is the only time that somebody could experience symptoms. And of course, now we have this knowledge that that's just the tip of the iceberg when you see obstructive coronary disease, that there's a lot going on in the microvasculature, that can be part of it. And having plaque present, regardless, of whether it's obstructive or not, that it has a relationship with symptoms and it isn't benign. And that when people have symptoms, that those are genuine. But even obviously, Dr. Kalra and I focus a lot on prevention. Even when you just have plaque present, you at least have an increased risk, even if you're asymptomatic. So when we see plaque, now our response is also very different for the many reasons that were just pointed out by the presenter, that we have to think about plaque differently and think about atherosclerosis differently. When we wrote the chest pain guidelines back in 2021, in fact, we redefine coronary disease, because at that time, coronary artery disease, when you used that term, you meant that they had a lesion of 50% or greater, depending on how you defined it. Some people meant 70% or greater, but 50% was kind of what we would see. We actually said if you have 0% stenosis, then I guess you don't have necessarily coronary disease that we can see. But once it's 1% or greater, they have coronary artery disease. And so I think that's really also shifted the conversation to some degree.
Amazing, great. I guess following this very insightful feedback and comments, so Dr. Gulati, I guess my question to you, like, what do you see the most realistic kind of like entry point for clinicians who want to integrate bleed biology into practice?
Well,
yeah, so go ahead, Martha.
Sorry. I think that is a really, that is the key question. I think that, you even from primary prevention, you can integrate plaque biology by shifting from really a risk factor only model to really, to a find and treat atherosclerosis early model. And I think that's the way that I think of it, that when we are using tools to detect subclinical plaque or interpret plaque phenotype, that we can match that to the therapies that we decide to use. And so, yes, it's important for us to understand risk factors and treat risk factors. Obviously, that's what we all know. But thinking about the target as arterial disease is a way to shift the conversation, particularly in primary prevention when we're using all these wonderful cardiac imaging techniques. And I'm not a cardiac imager, so I'm just going to say that straight up front. But as a preventive cardiologist, obviously I order and use imaging because that now is, we have those tests available, but then we have to know what to do with the data. And I think that's where the challenge still remains. I think that it's good that we have these techniques to detect not just atherosclerosis, but high risk plaque, that if we know it's high risk plaque, what are we going to do with it? If we know inflammation, again, what are we going to do with it? Because that's really, if you see inflammation in your imaging, does that mean we start treating inflammation? And we don't necessarily have full trials yet that are really guiding us in that way. I think that, of course, when we see plaque of any type, we're definitely thinking, okay, LDL needs to be at goal. That is hopefully going to help us reduce plaque volume. There's evidence that it reduces the lipid-rich plaque and makes it more calcified and therefore more stable. It reduces cardiovascular events by lowering LDL. And I think that's where we have the strongest evidence, but that's just one part of treating what we see on imaging. When we see inflammation clearly drives plaque vulnerability. And of course, we have data related to inflammation, related to high sensitivity C-reactive protein and how we might approach it from either from LDL or targeting or thinking about other anti-inflammatory medications like colchicine. But when we see inflammation on imaging, would that be the same response? Like, meaning, do I pull out things like colchicine? And I can't say that I have the full answers on that because we don't have trials that are guiding us in that way. And similarly, when we see other high risk plaque, again, what do we do with that entirely? And I think that this is the area where research really needs to go so that we know, once we identify it, once we're using it in a clinical practice, what do we do with it?
Yeah, I'll just amplify that and add to that. I think the framework of assessing patients is shifting increasingly so from just using clinical risk tools like PREVENT or PCE to more often incorporating an imaging tool, whether you use coronary calcium scoring or vascular ultrasound of the iliofemorals, or you have an opportunistic CT showing calcium, opportunistic CT angiogram that shows plaque. Integrating all of that information yields a better discrimination and prediction of the patient's future risk.
Amazing, great. These are all fantastic insights. And Dr. Kalra, how close do you think are we incorporating inflammation-aware imaging into routine clinical decision making before we start taking some questions from the audience. I would love to hear your perspective at this point.
Yeah, so if I think the advent of tools like pericoronary fat inflammation has really increased our ability to directly correlate inflammation with outcomes. So, you presented wonderful data on the CRISP CT study, and a larger trial of 40,000 patients, which was Orphan, showed that the presence of inflammation, so a high FAI index, when added on to other markers, such as clinical risk tools or plaque burden, it outperformed all of those other markers that we conventionally use. And as Tatiana mentioned, you don't really have to do anything extra to the patient to derive the FAI information. It's on the same scan, which basically gets processed for that additional information. There's no extra radiation, contrast, time, etc. So it's really powerful information that's embedded in that scan. And because its net reclassification index and predictive value exceeds that of other coronary high-risk plaque features, it's wonderful information to have. But as Dr. Gulati correctly pointed out, at the moment, we don't know which specific therapies you should add on. I mean, a lot of people would say, sure, I'll throw in colchicine, but that data is getting muddled after OASIS, the Class 2B recommendation a few years ago. But what do we actually do with it? And how do we tailor our therapies? Those trials need to be done and inform the space.
I think when I see that, Dinesh, I also think like if the patient doesn't have their high sensitivity C-reactive protein checked, I tend to go and check that. And then I think the other things that we can do clinically is like, treat things that cause inflammation too, like treat obesity, treat insulin resistance. If they smoke, treat that, because those are all things that cause inflammation. And sleep apnea is another thing that is associated strongly with inflammation. So making sure if they have sleep apnea or screening for sleep apnea, all of that is kind of my way of trying to deal with inflammation if the first sign of inflammation for me comes through imaging.
No, these are amazing, and speaking of the trial, I think there are many of the randomized trial that we currently have focusing imaging endpoints for inflammation limited to phase 1. We're still trying many new drugs, and mostly we focus in people with chronic inflammatory conditions like with rheumatoid arthritis or those with HIV, which have a high risk for inflammation. But I think it's still early to incorporate that into kind of clinical practice. But I think we are in the way, and especially with the release of the ACC statement recently about inflammation. I think that one of the first, or I think the first kind of a official or formal position about talking about inflammation as something that we should target. And we could go more upstream to the cardiometabolic risk factor that drive this. We can even go more. We can look at the environment and what other kind of contextualize the factors that drive all of these factors that eventually will lead to inflammatory environment. One question from our audience, and I think a very good question: how and when should we begin assessing Blake in peri and post-menopausal women?
That's actually a really great question. I mean, I think that in general, our recommendations for plaque assessment still are a little bit, depending on what groups you look at, for above the age of 40 for men and then above the age of 50 for women, because often, especially when we're talking about calcium, you're not often going to see calcium scores elevated in younger women. And so it really is around the perimenopausal timing that you might start seeing something. But in terms of using other imaging techniques, I will say, at least in the US, getting things like a CCTA or PET or any of the imaging that we have available generally is reserved for people who are symptomatic. And so we're not to say that it doesn't happen. We all know that people are getting CCTAs when they're asymptomatic, but that means that they have most likely had to pay for it themselves, but under an indication that insurance will cover it, at least in the United States, they have to be symptomatic. And so using it as a primary prevention tool tends to happen after people have said that there's not anything cardiac going on. They got the test. Somebody says, well, that, this isn't the reason for the symptoms or whatever. Then they become our patients and we focus on prevention. But I wouldn't say that every patient comes out with the test that we were just talking about, aside from a coronary calcium score. Dinesh, would you say differently? I mean,
no, I agree with you 100%. I think, as you correctly pointed out, there's not yet appetite or the data to drive mass screening with coronary CT angiograms. And our guidelines very clearly lay out when you need additional imaging. For example, in the case you mentioned, and you've been a worldwide expert in driving this conversation, is women have specific women-related factors that elevate their risk, whether it's eclampsia or preterm labor or other pregnancy-related factors that led to an increased risk. Those people can be shifted to a higher risk category. And if your risk category has already moved to an area where a statin is indicated, then that sort of ends the conversation and you have a therapeutic plan. But if the patient is hesitant or you're not clear and you need to refine the risk, then you can go into the space of imaging, generally starting with coronary calcium scoring, and then you can move into these other areas if there's symptoms or you're investigating a little deeper. There are trials ongoing that are enriching patients with, say, for example, diabetes in older folks and looking at coronary CTA, but we won't have those results for 4 or 5 years from Transform, et cetera. So that's not yet for mass application. I agree with you.
Thanks so much. We really thanks you both. That was incredibly practical discussion since we are to stick with our timing. So now we will move from what we can assess today to what is really emerging next. And our next speaker, Dr. Nicola Giannuti. Over to you.
Thanks, Shady. It's a pleasure being here, being invited as a speaker. My name is Nicola Giannotti, and I'm an academic at the University of Sydney. Good morning, everyone, once again, and thank you for joining me and us today. Many myocardial infarctions and strokes may arise from non-obstructive stenosis, plaque that only cause mild narrowing of the artery. Non-invasive imaging with CT, magnetic resonance imaging, and ultrasound may identify important morphological features of high-risk plaques. However, these techniques cannot directly assess the ongoing inflammatory activity within plaque. Inflammation is one of the critical hallmarks of plaque instability and one of the primary triggers for plaque rupture and erosion. And this is why, this is exactly why positron emission tomography might become such a powerful non-invasive imaging tool, as it might provide functional, molecular, biological diagnostic insights into plaque inflammation by targeting increased metabolic activity or specific inflammatory pathways, potentially allowing us to detect truly high-risk plaque, even when the artery looks normal. The inflammatory theory of atherogenesis points to the destabilizing effects of physiological and immunohistochemical processes, which increase internal stress within plaque as important causes of plaque vulnerability. But before we look at the specific tracers that are being used mostly in the research setting, let me quickly highlight some key biological processes that might drive plaque instability and that might be imaged by positron emission tomography. These include active vascular inflammation, leading to markedly increased plaque metabolism, macrophage accumulation, presence of microcalcification, and lastly, hypoxia, where low oxygen areas might trigger the development of fragile new blood vessels into the plaque. Unfortunately, all these cannot be imaged and interrogated by computed tomography, magnetic resonance imaging, and ultrasound. We have positron emission tomography tracers that might specifically target each of these processes. FDG is probably the most established tracer, is a glucose analog that highlights plaque inflammation related to increased metabolism. Sodium fluoride binds to hydroxyapatite and detects microcalcification. Gallium dotatate targets somatostatin receptor subtype 2 on activated macrophages, potentially giving us a more specific marker of macrophage-driven inflammation. And lastly, F-MISO images hypoxic cells, and in previous studies has been associated with neoangiogenesis. Altogether, these tracers could give us a biological fingerprint of plaque vulnerability. On this slide, we can see some examples of how FDG and dotatate were used on a large vessel, such as carotid, and demonstrate a higher uptake corresponding to low attenuation plaque on corresponding CTA. And on this slide, we can see how sodium fluoride has been uptaken by clearly calcified area on CT, but demonstrated the potential to identify microcalcification even before they can be visualized on conventional imaging. And lastly, it's an uptake of F-MISO corresponding with associated with corresponding uptake of FDG, and is thought to bind to an area of plaque, hypoxia, and neoangiogenesis. In a recent scoping review, from the result of a recent scoping review, we can see that the PET imaging landscape for atherosclerosis is largely dominated by FDG, with a few studies that explore the opportunity to run dual tracer, potentially targeting different biological processes occurring simultaneously within active plaque. Limitations of conventional PET imaging include high radiation exposure, generally high cost and limited availability. FDG, which represents the most used radiotracer, does not show specific uptake in the myocardium. Motion artifacts in the coronaries is also a technical limitation, and generally from the results of this scoping review, we can see that there is a substantial protocol heterogeneity across studies with limited standardization. PET technology is advancing rapidly with long axial field of view total body PET scanners, which demonstrated up to 40 times higher sensitivity, ultra low radiation doses, the ability to perform dynamic kinetic modeling analysis, and the ability to image multiple vascular beds simultaneously. This means that we might potentially quantify plaque inflammation more accurately, assess systemic atherosclerosis burden, improve coronary imaging, and use very low dose protocol. Following up on what Tatiana mentioned earlier on, CT angiography can interrogate features of high-risk plaque, such as positive remodeling, low attenuation, spotty calcification, and the FAA. Moving forward with technology, the photon counting computed tomography was introduced to the market towards the end of 2021. While conventional multi-detector CT systems rely on a two-step process to convert X-rays into light, Photon counting CT detectors directly convert X-rays into electrical signals and enabling them to count individual photons and measure their energy. So that intermediate step from X-ray into light into electrical signal is bypassed with a direct conversion of X-ray into electrical signal. Technological advancements from the photon counting computed tomography include improved spatial resolution, lower electronic noise, increased contrast to noise ratio, the potential for artifact reduction, a reduction of the partial volume effect, and improved tissue characterization. Despite being a quite novel imaging modality, the initial results and initial papers published over the past couple of years showed that image quality improved with photon counting computed tomography compared to a conventional multi-detector CT. These might enable new avenues for the interrogation of critical markers of plaque instability, such as the tiny fibrotic cap, or better assessment of plaque lipid-rich necrotic core. And finally, it also enables a non-invasive assessment, a better non-invasive assessment of coronary stent patency with higher image quality and diagnostic accuracy, thanks to the improvement in the detecting technology. In conclusion, hybrid multimodality imaging merges molecular detection of plaque inflammation with anatomical resolution to enhance plaque characterization. Unfortunately, current protocols' heterogeneity and limited evidence must be addressed to help translate PET imaging into clinical practice. Novel imaging technologies have the potential to improve risk stratification and therapy monitoring. Thank you.
Oh, thank you, Nicola. That was a fascinating overview of all molecular and bit-based imaging and CCT of plaque inflammation. And there is a really exciting potential for the total body PET. So let's bring back our panelists, Dr. Gulati and Dr. Kalra. So I'll begin with this question. So if we really accept that plaque vulnerability, not just stenosis, drives most of acute events, what role do you see for PET-based inflammation and other evolving techniques like CCTA, photon counting that Nicola just spoke about, for the future prevention paradigms? Like how and like what does it really specifically for the total body PET realistically fit? Is this like you think it's a research tool, or do you foresee there is a broader clinical translation?
I can start. I would say that right now it is a research tool. I mean, I think that we, both because of cost and availability of these tools, not everybody has PET imaging in their backyard. Some probably at academic institutions we do, but not in real practice. I think we also, before we, we're the cardiology community, we demand trials to show us that if we intervene on something that we're actually changing outcomes, how many lives are we saving by doing what we're doing? I think theoretically, obviously, our imaging techniques are getting extraordinarily, to the detail that you showed, that Nicola showed in his presentation, just showing what you can see and the degree of what we can discriminate. So this is exciting. But I think the people currently in my clinical practice who get these tools and get these imaging modalities are symptomatic individuals. Somebody who is symptomatic, we send them for tests. We're not using them in asymptomatic primary prevention patients. And so when we find something, where do we categorize them? If they haven't had a cardiac event, they aren't secondary prevention. They're not really primary prevention. And I guess I throw them in my own category, as many of us say, primary and a half prevention. So that's where I see that we get, when we have that information, we have the ability to act on it. And I think there is a bit of onus on the imagers too, to convey that information. I mean, like I said, I'm not an imager, so if it's in the report or if I'm looking at it with them and they show me these things, then I'm like, okay, here's the things we're going to do. We have to make sure this information, though, gets into reports rather than if we sent the patient for detection of ischemia and if the report simply comes back whether they saw ischemia or not, and not tease out all this important information, then we don't have the chance to use it in our clinical practice.
Yeah, I just want to emphasize again what Martha said, really important points about this is a very promising technology. I see it really taking off in the next 10, 20 years. Obviously, there's considerations of cost and standardization of protocols and all of that. But going back to what Martha was saying, this has currently been used only in secondary prevention. So even if you take the application of, say, sodium fluoride PET, which was tested in a trial a few years ago, these were patients who had prior myocardial infarctions, and it kind of missed its primary endpoint, but there was signal of benefit. There are about 700 patients who had an event, and so the presence of microcalcification activity on a sodium fluoride PET predicted that patients would have future events at a higher rate. So promising, but again, if you step back and say, well, I don't know what to make of that yet in terms of what do I need to do with therapy. Obviously, I'm going to increase lipid prescription and intensification and get their LDLs down to as low as possible. But that's not yet been tested in a clinical trial, i.e. if you had that information versus if you didn't, and then you act on it accordingly to fix all the reversible risk factors, are you improving outcomes? So I think stepping back and having that picture is good. I love research. I'm an avid researcher. I do imaging all the time, but for the general audience, I just want to say, first, you want to optimize the lipids, get the CRP under control, and then this is all fantastic. It's coming out. The second tool, as you mentioned, gadotate, that's a little less applied at the moment in clinical trials. The proof of concept is wonderful. You have macrophage activity, it lights up, indicates higher risk. Same thing with FAI. Like you earlier mentioned, you have FAI for CT, and you give a drug like ortikumab, which binds oxidized LDL, or you give an anti-TNF or IL-6 blocker in psoriasis, you decrease inflammation. But then we have to show that this translates into something else, better outcomes, because we do that. And that's sort of where the field is moving. I think, again, just to emphasize, very promising. This is with PET, CT. There's also stuff going on in MR and vascular imaging. You can tag all kinds of tracers to MR as well as even micro bubbles with ultrasound. I think this field of imaging and detecting inflammation is moving, but I think the most promise at the moment is with PET CT.
Great and amazing. So, you mentioned a very important point about, there is definitely a promise of all these advanced imaging, but there's some limitation about kind of radiation and standardization for the protocols and the cost, and most importantly, accessibility. There are many recent studies show that really, if you speak about the US, they really have a limited access. And if you look at geographically, people have limited access to the closest center CT or PET imaging facility. How do we balance kind of the promise of these advanced imaging with the cost, radiation exposure, and accessibility, especially with the evolving? And there's many tools now. If we kind of talk about the clinical applicability using AI and deep learning and how we can drive imaging-based biomarkers from these endpoints, especially involving them, incorporating them in clinical trials. With this evolving of the AI and maybe will expedite and we will save much money or cost, how we can take this all together and kind of accelerate the clinical applicability of these advanced imaging, and we balance all these limitations that we just mentioned.
So, let me start off by saying I think PET is not affordable by everybody. You showed the whole body PETs; those are about $10 million at least, right? So it's not something you can put in your backyard. A few academic centers have it, and as you and I were talking, even there, it's mostly in the research space that people are doing sodium fluoride or gadotate, etc. So at the moment, it's not ready for prime time, but as a research tool, it's fantastic. I think what is really maybe imminently practical application is going to be the FAI tool. So it's awaiting FDA clearance in the US. It's already approved in the EU. As we mentioned, it does not require extra radiation. PET still gives you, extra radiation. So if you take a typical PET CT, sodium fluoride or gadotate, etc., you're talking about 5 millisieverts add on to what you're doing with CT. So not huge, but not trivial either. So you have to factor that in. So I think cost becomes an issue, access becomes an issue. The AI tools, at least for plaque in the US, are currently being reimbursed. So, total plaque burden, non-calcified low attenuation plaque burden, as you mentioned. And then the interesting thing is tracking that over time. When you change therapy, if it reduces, does that mean something? I think time will tell us. So I think that's what's going to be the sweet spot, most actionable right now, is sort of these plaque metrics you're getting by AI with CT. The PET stuff is probably still in the research space for another few more years.
Yeah, I totally agree. I don't have much to add. I think it really is right now a research tool and so limited in terms of availability of PET that we're certainly not able to do it in the United States. But I think we need to think about all the tools we have for cardiac imaging, for risk assessment. What is the cost? And then what is the return on investment, if you will? If you're going to use something, what will we get out of it as a population? That's the way that our country should look at it, to really know, are these tools going to be practical? We want, sometimes the simplest things aren't being done. We know there's enough people not just, not always even getting their lipids done, or those of us who, LP little a or C-reactive protein, things that could change how we treat people and intervene earlier. And I think that if we're going to exert efforts in our prevention space, those things to me are right now the priorities versus expensive imaging for all. And I think that, I know that everyone here probably is being trained in imaging. And of course, it's an important part of what we do. But I would highly recommend, we just at the end of last year, we published a review paper that some of you might have seen in Lancet on the contemporary non-invasive imaging of chronic coronary disease. So not really on the prevention space, but more from how we manage these patients. And I think it's a really good review. It was published in the Lancet. So the senior author is Dr. Bax. So if anyone wants to look it up, but I think that's an important way to sort of think about where imaging is appropriate and where we need a little bit more work.
Very nice. If we're gonna think of imaging, like inflammatory imaging biomarker, for both of you, which imaging or inflammatory biomarker that you think will have the strong near-term clinical potential, and also which patient profile today do you think gonna most benefit from kind of inflammation aware imaging?
So for me right now, the biomarker that I use is high sensitivity C-reactive protein. It's cheap. We have data on it, so strong data. Some of you may have seen the really important work from both the Women's Health Study and from the European cohort. Dr. Ritker was one of the authors. I can't remember in which position, but I think that data is really strong in terms of the value of high sensitivity C-reactive protein, and also the things that I just said, the LP little a and LDL. And if you have all three, you're at a much higher risk. If you have one, you're definitely at a higher risk compared to having none of those present. And I think that's an easier way for us to think about prevention. And when we think on a global scale, it's accessible for pretty much every country, whereas cardiac imaging, sometimes that's the challenge, right? We can do it when we live in the Western world where we have accessibility, but not so easy to do depending on other geographic locations.
Yeah, again, not to minimize what Martha just said, because that really was where the focus should be. But I know this is an imaging geek crowd. So your question was, if your question is what do we use for PET imaging for inflammation? I think it depends on what you're trying to answer, right? So microcalcification, not really active inflammation, but what happens downstream when active inflammation's happening, you get hydroxyapatite crystal formation. Sodium fluoride is great. I talked about the one trial where there's good data that if you have sodium fluoride uptake, you got activity in the plaque. But we sort of confuse histological activity with an endpoint. So this is still one step downstream of that, microcalcification. Good. Gadotate, again, macrophage, somatostatin uptake. Again, all of these are good as sort of proof of concept tools, and they need to be standardized because, the coronaries are tiny. You're looking at proximal vessels, you're looking at uptake, and depending on the protocols, the kinetics of the tracer you're giving, the background activity, your sensitivity for detection, I think all of those things have to be sorted out. So if I were to pick two that I really like today, it would be the sodium fluoride PET and gadotate for the various reasons I mentioned and for what process you're looking at. But that doesn't mean MRI isn't good. In the carotid plaques, MRI is fantastic. You can pick up edema, you can pick up T1 fat content, you can use contrast to see which plaques are inflamed in the carotid. So depending on the coronary bed or carotid bed, the technique varies. But for the coronaries, it's the two I mentioned.
Very nice. I want to quickly follow up on this by a nice question from the audience. Like they ask about if there is, like in the era of semaglutide and all the GLP-1R1, do you think are there any certain limitations for cardiac imaging when it comes like FDG or like when you just that we should keep it in mind?
Can you say your question again? I'm sorry.
I would say they were asking like in the times of semaglutide and all these GLP-1R1 drugs. Are there any certain limitation for cardiac imaging? So like when it comes to FDG and other types of modality that we should keep it in mind in this era?
Yeah, so I mean, people have studied. First of all, FDG for coronary imaging is not great. Why? Because the myocardium loves glucose, so it mops up the FDG. So you're trying to basically segregate coronary uptake from myocardium that is right underneath it. But the point of semaglutide overall is fantastic. I mean, these drugs have not just effects on weight and paracrine and adipose tissue, they have direct effects on plaque biology and lead to regression of plaque. And we have a trial ongoing where we're using semaglutide and looking at CT. And our early data already shows that as used in one component of aggressive treatment, it does reduce inflammation as detected by low attenuation plaque, etc. So I think the addition of these drugs, along with things like colchicine, etc., will probably yield benefit down the road. We don't have the trial data yet, but that's my guess.
Thank you. I mean, I want to thank you both. This is a truly stimulating discussion. So now I would like to invite Dr. Jessica Benifer to share kind of key take-home messages from today's discussion. To Jessica.
Well, thank you, Dr. Kalra and Dr. Gulati. That was really a wonderful discussion. I want to thank you really for sharing your insights, both, I think, very clinical insights for those of us who see patients, and exciting to think about what's coming ahead. And really, I think, highlighting the importance of having clinicians guide implementation and the design of studies. So I think if I had to summarize some key takeaways from Dr. Storozhenko's talk is really to remind our colleagues that the presence of plaque, that binary presence or absence of plaque, is really an outdated concept, and we need to think beyond the presence or absence of plaque to think about biology and inflammation, and really to remember that inflammation is a part of every, not just the propagation or progression of athero, but it's present from the inception, and so really all stages of plaque, even people who don't yet have plaque that we can see. And there are various imaging modalities that we talked about, those that are readily available now. We talked about opportunistic screening. Dr. Kalra mentioned, using what we have available now, modalities like cardiac CT. And then we talked about modalities that are primarily for research, but that can help us understand how, what the therapies that we have available and that will come are really doing with plaque. And then last, I would say, is really just the need for more evidence. We need to know what to do with our patients, like Dr. Gulati mentioned, and we have a high standard in our field for evidence to guide interventions. And so, as these imaging modalities continue to evolve, we really have to have the evidence for interventions that that improve outcomes that we and patients care about. And I would add that we also always need to think about implementation, clinical implementation, because what works in a research setting isn't always what works in the clinical setting. And Dr. Gulati, I think, gave us some pearls to remember that there are things that we can do now. Many lifestyle, I always remind patients that things like exercise, taking a statin, right, they all reduce inflammation. So there are a lot of things that we can do now. And I think that's it. So thank you all for joining us. Thank you again to our panelists, and thank you really to our fellows who led the development of this webinar. Thank you for all your hard work. I certainly learned a lot. And I'll end by giving you the save the date. We have a triennial Congress, our next Congress. If you want to hear more stimulating discussion, science, will be in Santiago, Chile, October 20th to 22nd, 2027. So I know it sounds like it's far away, but it'll be here before you know it. So please save the date.
Thank you, Jessica. That was an excellent synthesis. So before we close, we would really appreciate if you could just complete for the audience, complete a short evaluation survey. That your feedback would really help us shape our future IAS educational initiatives. And again, just before wrapping up, so today's discussion really reinforces an important shift in cardiovascular prevention. And I want to, on behalf of the IAS Inflammation Academy Fellows, thank you, Dr. Kalra and Dr. Gulati, for your insights. And thank you to all for joining us from around the world. We look forward to seeing you at our upcoming IAS events and webinars. Have a wonderful day.